Thank you so much for the invitation. I'm thrilled to be here speaking, and at least it's not midnight here, like for some of you. And I'm from Argentina, so I'm close by to Cali relatively, but I live in Colorado now. So, okay, without further ado, let me share my screen and try to enlighten you all about the GI anomalies. So I'm going to try to make a potpourri of cases. I have no disclosures. And I think that the main objective of my talk is to highlight the importance of fetal MRI in the evaluation of GI abnormalities, these complex ones. So I'm going to do some anorectal malformations, but some other more bread and butter GI abnormalities. So we heard from Trevor a very nice talk about some of these anorectal malformations. Just so you know, prenatal diagnosis of anorectal malformations is very rare and is very difficult. Most of the diagnoses in utero are those severe anorectal malformations. So approximately 16% or 1 in 5,000 are diagnosed. And these involve the severe forms such as cloacal or cloacal exstrophy, while other forms are less easily identified. And I think this 16% only catches those that are severe and easy to identify. So we're certainly missing to diagnose quite a bit of them. I'm not going to rehearse this talk, but just this table, but just so you know, there are many publications that talk about the variety of cloacal and anorectal malformations that we can encounter. And this is a great table that sometimes I go to when I struggle with some fetal case. So these abnormalities are typically detected in the anatomy ultrasound that in the United States is typically done between 18 and 22 weeks, where the mom goes to the OBGYN, the ultrasound is done to make sure that all the anatomy of the fetus is normal. So the key organs to evaluate are the kidneys and bladder, the bowel, the genitalia, including the vagina and the uterus, the anal dimple, we'll talk a lot about that, the lower spine and the sacrum, and other abnormalities such as heart that could be part of the Bager syndrome. The most common prenatal abnormalities for anorectal malformation or GI abnormalities of this most severe type of abnormalities are an abnormal pelvic cyst, which is a typical referral that we get by ultrasound, and that most likely represent hydrometrocolpus. Then you can also find hydronephrosis, oligohydramnios, ascites, and other abnormalities. So I think that we have a very varied audience with different expertise. So I'm going to be very quick about showing some normals that could set the stage for understanding the abnormal images. So by ultrasound, we have the bladder, and it's very important to identify the two vessel cord. So you're going to have the two umbilical arteries going on each side of the bladder. It is customary to also get a long view of the aorta with the two renal arteries to prove the existence of them. And this is how the kidneys will look in the coronal plane in ultrasound. By MRI, the kidneys in the T2 images that we mostly do are going to have the shape of a letter C, and the letter C is going to face each other where they're going to face the spine. So keep that in mind because there's many ways that the kidneys can look abnormal. The bladder is best seen on the sagittal view. In many views, we see it. But it's very important in the sagittal view because you also see the relationship with the colon, the rectum, and the genitalia all in one. Okay, the anal dimple. In the SPR, sadly, I'm known as the anal dimple queen. So I don't know if I need to embrace that. But anyway, hopefully you can remember this from my talk. So the anal dimple is very important because if we start paying attention to this, you can identify a lot of abnormalities that could help diagnose anorectal malformations such as imperforated anus, and that will change the management of the patient. So by ultrasound, in a transverse cut at the perineal area, you're going to see this oval or slightly rounded appearance that is hypoechoic, and it has a center of hyperechogenicity, or somewhat like a target sign, not necessarily very, very rounded. And then the fat of the perineum in the baby. By MRI, you're going to see the same thing, but you need a very strict plane that the axial plane of the fetus is axial to the perineum and not necessarily well aligned to the rest of the abdomen. So this is an SSFP image, and this is an SSFSC, both situated. So you can see this rounded oval of rounded hypointensity in both sequences. We don't see that center of hypoechogenicity as we see in the ultrasound. It's more homogeneously hypointense. And then you have the surrounding adipose tissue of the perineal area of the baby. That's the normal one. It's good to look at the normal sacrum. Most fetuses by 17 weeks have ossification of S4, and that can help you identify some sort of sacral anomalies. The bowel, depending on the gestational age, the small bowel is going to be fluid filled and the colon is going to have hypointense appearance. But early in gestational age, it kind of all looks the same. So just keep that in mind. The colon is going to have darker signal, particularly at the rectosigmoid. That's where the meconium starts distally and grows progressively. So in T2 images, it's going to have a dark appearance and it's going to be obviously bright in T1, as we see here. So this is a T1 image. We tend to do M. Dixon images. We have a Philips scanner, so we don't have the Vibe or the other sequences that others have shown. And we get the 4 views with fat suppression, water suppression, etc. So in this view, the sagittal, you can see the meconium colon is bright in T1 and the dark bladder anterior, the corresponding T2 image. And this is the coronal image. This is obviously looking a lot darker, but this image is also important because it helps us identify if the colon is following the normal expected positioning. Normal genitalia. In girls, obviously, the labia, this is how it's going to look by ultrasound. And in males, it's also very important. You have the scrotum, the phallus, and in MRI, we even get to see this line that starts closer to the baby and it goes it kind of pushes out. And then you see the scrotum underneath. And I'm making this remark because I'm going to show you a case where this abnormality can be inverted or can be abnormal. So the phallus has to have this disposition and the scrotal sac has to be below. The uterus is hard to see unless it's fluid filled, and in most cases it's not. So it's really hard to see. So in the axial view, you have the fluid, the bladder, the uterus behind, and the rectum. So you can see 3 circles. And the older the fetus, the better you're going to see it. In the sagittal view, you're not going to see it neither in the coronal unless it's abnormal. All right, so let me show you a couple abnormal findings. So this is a normal anal dimple, as I showed you. This is an abnormal dimple. So in the trans view by ultrasound, you have a rounded, larger appearance, and it seems like it has 2 central areas of hyperechogenicity. That was abnormal. And this ended up correlating with this appearance of the anal dimple or the anal sphincter in this baby. So it had this amorphous amount of tissue. And this baby had indeed imperforated anus. So by MRI, what you're going to see is you're going to see a line. So instead of seeing the rounded or oval area of hypointensity, you're going to see the line, the same thing by ultrasound. And it's important to correlate that with the T1 images to see where does the meconium end. And in this case, the meconium was ending too proximal, too higher up compared to the level of a perineum. So we suspected that this was imperforated anus, and indeed it was. The inversion of the meconium signal is also very important, as Trevor already, Dr. Gaunt shown us earlier. So in the T2, this should be dark, but is white. And in the T1, this should be white, but is black. So this is inversion. And this happens when there is a mixing of urine and meconium. And sometimes you can have precipitates in the rectum, and that will form the fecalith, which are going to look like dark dots within the rectum. So that is very pathognomonic of mixing of these 2 structures. And these are the comparison normal images for reference. The sacrum can be blunted, can be abnormal, and we know by postnatal imaging that can have a scimitar appearance, can have absence, partial, complete agenesis, etc. So by fetal MRI is hard. And I put this image, but the most helpful image that I find are the bright blood technique, the SSFP coronal images to look at the shape of the vertebral bodies. So in the sagittal view, we can see in these fetus that the spine ends too short and it doesn't taper as it should. And these are the comparisons of how it should look. And by ultrasound, you can see that it has irregular appearance of the vertebral bodies and it ends abruptly. So that was a truncated sacrum. Hydrometrocolpus, we're going to see it particularly in cases of cloaca. The most common Mullerian anomaly in cloacas is a didelphous uterus. So in this case, in the axial plane, we have the 2 hemivaginas and the bladder anteriorly. In this case, there was also ascites. And this little tubular structure here, that is one of the uterine horns. And what happens is through the fistulous connection, the urine goes into the vagina, through the uterus, and through the fallopian tubes, spills fluid into the peritoneum. And that's what we get the ascites. So these cases are highly obstructive because they can't drain anything via the urethra or the channel. So then they go back into the abdomen. We tend to have hydroureteral nephrosis. These are the ureters, very fluid filled and dilated, the bladder, and the ascites. And then here you can see the kidneys that have thin cortex and central and peripheral urinary tract dilation or hydronephrosis, and the same appearance is seen in the ultrasound. Okay, let me show you a couple cases. So we're going to start with case 1, which is a 30-week female fetus referred to us for hydronephrosis and a pelvic cystic mass. And every time you get a referral for a pelvic cystic mass, in your head, you need to think, if it is female, most likely is the uterus. So let's keep an eye on that. And if it's male, then or better off, but you need to go down through your differential. So in this axial plane T2 image, you can see this cystic collection or cystic structure, the kidney that has a cyst posterior to it, and it corresponds to this hourglass perinephric cystic collection. The kidney underneath looked very abnormal. It had very bright signal in the cortex with cystic dysplasia, and the contralateral kidney had hydronephrosis. Well, more anterior to that was this cystic structure, which was the vagina, the cervix, which is going to have dark signal intensity, and the uterus right on top, fluid filled. In the sagittal view, again, we see the vagina, the bladder anterior, the cervix, and the uterus. And interestingly, the sagittal T1 image showed near no meconium, very, very faint, posterior to that. So this is a case of a classic cloaca. We're now good at saying classic versus posterior cloaca in utero. This was confirmed postnatally, and this is the picture of that baby that has a single opening in the perineum. And this is a diagram showing how the 3 elements come into a common channel at the anterior orifice close to the urethra. The patient had a colostomy at the first 24 hours of life, and then afterwards we do a high-pressure colostogram. So we do this in fluoroscopy or in the IR suite, and we inject contrast high pressure, although this is hand inject, to fill the distal rectum. And then we put a BB marker or a clamp or some sort of instrument that tells us where the perineum is, where the anal dimple is, to figure out what is the length between the distalmost aspect of a rectum scene and the perineal opening, because that helps the surgeons identify how they're going to do the surgical approach. This is the renal ultrasound postnatally showing the abnormal increased echogenicity of that kidney with the perinephric urinoma that was seen, and the hydrometrocolpus with the fluid level and the bladder. Somewhat similar case. So axial view, 26 weeks, referred for ascites and a pelvic cyst. So these are the 2 umbilical arteries going around the bladder, as I showed you before in a normal patient. And you can see that there is also ascites and these 2 cystic structures in the pelvis. This same patient had an MRI, and you can see the bladder with the 2 umbilical arteries here in dark signal, massive ascites. 1 cut posterior, you see the 2 cystic structures, and this entity coming in between these 2 cystic structures, which has a light gray appearance, and then a little bit more posterior has more hypointense, although mixed signal intensity, and you have other tubular structures close by. So these are the 2 hemivaginas, these are the 2 hemiuteri, and this is the rectum coming in between the 2 hemivaginas, which is the most pathognomonic finding. The T1 images show mixed signal and abrupt termination of that part of the rectum coming in between the 2 hemivaginas. So what this is a posterior cloaca. Again, not that I said posterior cloaca in utero, but postnatally was diagnosed as such. Patient had a colostomy, and this is a postnatal cloacogram done in the IR suite, where we were able to do fluoro CT reconstructions. So we inject contrast through the fistulous connection, refluxes into the 2 hemivaginas, and then the patient also had a Foley catheter, so we filled the bladder with contrast. And in the fluoro CT reconstruction done with the C-arm of the IR suite, you can tell each of these structures very, very clearly. So again, posterior cloaca, which is the same thing except that the opening is posterior than expected. All right, let's switch a little bit. 25 weeks, 2 days, fetus came for dilated distal bowel, although I did not have an ultrasound available, unfortunately. So I'm looking at the T2 image, coronal, and I see that the column is really dark and, okay, not too surprising. I look at the anal dimple, and this is a bit of an oblique view. So here's one thigh. This is part of the other thigh. This is the posterior aspect of a pelvis. This is the anterior towards the genitalia. And this is the anal dimple. And a little bit above that, I see that the rectum does look a bit prominent. The T1 images in the coronal and sagittal plane show me that the rectum was thicker, was wider than expected, and disproportionate to the size of the rest of the bowel. So we recently published a nomogram in the size of a rectum and colon, and we were able to measure this and compare this with the chart that we developed. And I actually printed this and put it right on top of my monitor so I don't forget to check. So these baby fall way above any of these normal parameters for the rectum and sigmoid in both coronal and sagittal. So the anal dimple was normal. So these are the cases that are really challenging, because what do you do with this? How do you counsel the family? So what we said is, it seems like the anal dimple is opening, which would make the baby okay to deliver in a small facilities, sometimes in small towns where they don't have pediatric surgery. But this could be seen in Hirschsprung. We have seen this sort of anomaly in Hirschsprung disease. So we suggested that, but at least we're able to help with the perinatal management of these patients. Okay, another very interesting case. So let me see if the scene clip, there we go. So this was a baby that came at 29 weeks one day. They were twins. And one of the twins, the twin A, had a dilated stomach and duodenum, and there was polyhydramnios on that side. So in the cine clip, you can see the stomach very dilated, the pylorus and the duodenum very dilated to the proximal duodenum, and then boom, there was a stop. So that was the double bubble, consistent with what we think of duodenal atresia. The anal dimple was normal, and the T1 images, which I always look, didn't really reveal any obviously abnormal rectum. The anal dimple, I didn't get a great view. This is quite oblique. This is one thigh. This is the posterior aspect. This is the anterior aspect. And here's kind of the best view I found of the anal dimple. So I'm like, okay, the anal dimple is fine, duodenal atresia, but there is some meconium formation. And look at this comparison case. This is a case from far away. We do telemedicine in the state of Montana. And in these images, this fetus also has polyhydramnios. The stomach is very dilated, but the duodenum, actually, this is the duodenum, which is more distended than the stomach. So that was massive, very, very, very dilated. And the T1 images did not show any sort of meconium, bright meconium at the rectum or distal bowel. So you will see this variety. Depending on how tight the stricture is, you may or may not see. And again, as you know, the meconium forms distally and goes progressively, proximally. So pay attention to these findings. It's important to mention, but always look at the anal dimple, because you may find it perforated anus. And I have found it more than I imagine. Maybe I'm a referral center and I'm biased, but I feel like I can collect a lot of extra information. All right. There has been publications that the meconium can be abnormal in fetuses with myelomeningocele. And actually Cincinnati published on this. And the thought behind it is that there is this abnormal innervation of the pelvic organs because of the defect in the spine. So this was a 22-week fetus with obvious myelomeningocele, hindbrain herniation, the Chiari spectrum of abnormalities. And then when looking at the T1 images, I'm going to try to do a manual. So we have the liver. Actually, you can even see the thyroid there. That's very cute. You can see some of the bowel going down, but then it gets really skinny at the level of a bladder. And this is a sagittal view where you see the dark bladder and a very skinny line of a very faint, bright meconium in the rectum. So that was abnormal. These fetus, this was the first MRI before the surgery. So the anal dimple was overall normal then. The baby had a follow-up MRI 2 weeks after the MMC repair. That's what we do, standard of care in my institution. So the hindbrain herniation had resolved. And then we got a better look at the colon because the baby was older and larger. So you can see that the rectosigmoid, it's a little bit prominent and it tapers and it doesn't go all the way down to the perineum. And also in the sagittal view, obviously we have breathing motion artifact in here, but it didn't go all the way. So we mentioned that the meconium was abnormal, was not completely as we expected, but in the second follow-up, we couldn't see the anal dimple. What we failed to do is to say, what did that mean? What does that mean to have an abnormal meconium column and bright signal? So this patient went back to Montana and she delivered there. And thank God there's pediatric surgery because this patient ended up having a perforated anus. So we received follow-up. So this was a learning lesson that we need to be very explicit in our reports that if we see an abnormality, we can explain the clinicians what this means because not everybody's going to understand what a bright meconium or absent meconium is going to mean. So keep that in mind. Lesson learned for us. Okay, this is a great case. So this baby was 26 weeks, referred to as for ambiguous genitalia, had an XY by cell-free DNA. So the ultrasound shows 3 curvilinear lines at the genitalia. So we interpret this as 2 hemiscrotum and the phallus in the middle. And a better view of the phallus shows that it is broad, squared off, and kind of flattened towards the tip. And it should have a bullet shape. Okay, that's a very normal appearance of the phallus. But in the coronal view in the MRI, what I'm seeing is, so you have obviously the abdomen, one leg, the other leg, you have the 2 scrotal sacs, you can even see a hint of the testicles, and you have the phallus that is in between the 2 hemiscrotums and is actually heading south. That is the opposite to the line I showed you for the normals. That is abnormal. The sagittal view, so you have the spine, the butt of a baby, the thigh, the knee, you have the scrotum on top, and the phallus is underneath and is again heading south, not in a good direction. And in a close-up of the coronal view, you have again the hemiscrotums and the phallus in the middle. So this is a case of penoscrotal transposition. And these are very rare. And these are the most severe form of hypospadias because they have a proximal hypospadias close to the median raphe, and they require several stages of surgery for repair. So this is a picture of the actual baby. You can see the phallus again heading south and the 2 hemiscrotums at the top. So the situation is inverted. And this baby indeed had a proximal hypospadias. Not only that, but this baby also had imperforated anus. So in the T1 images, this is the right, this is the left. And you can see the bladder here and the descending colon that stops right there. And this is a better view where you see the blunted, abrupt cutoff. And this is a normal for comparison. So even though we didn't get to see the anal dimple very well, we have enough abnormalities to suspect, hey, something is really wrong with this baby. So this baby actually was born with us, and that's how we obtained the follow-up imaging. And this is kind of a close-up view of the baby to show that there was no anal dimple. Anal sphincter opening. The baby also had a tether cord and had segmental anomaly. So I think we ended up looping this under the Bacterial Association because we couldn't find any other genetic abnormality. All right, we're towards the end. Esophageal atresia. MRI is really not great at diagnosing esophageal atresia. We mainly use indirect signs. So you look for polyhydramnios. So this patient presented with a maximum vertical pocket of 11, so obviously abnormal. The stomach was very, very small. And then if you're lucky, you may catch the esophageal pouch fluid fill like in these 2 images. One is more oval, one is a bit more blunted. But this is infrequent that we get to catch the esophageal pouch. So we do the 20 millimeters slab bright blood technique cineclips. And here you can see the baby moving, swallow, and maybe a very subtle dilatation here, maybe very subtle. Again, we do this, there's a lot of motion artifacts. So that's what is really, really hard for us to diagnose it. This is the first chest x-ray of a baby. The anterior tube didn't go beyond this area, but obviously there has to be a TEF because the stomach was air-filled. And I love this case. So this was a 27-week, one day that presented with dilated bowel. By ultrasound, you can see all these fluid-filled loops of bowel. And in the MRI, this has a very, very distinct appearance. This is right, this is left. Actually, the images are inverted. But the point is, look at the symmetry in the fluid-filled dilated bowels. It's everywhere and it's very symmetric. So if I scroll through this, you're going to see that everything looks bright. You don't have the typical dark appearance in the T2 image of the bowel. All right. This is congenital diarrhea. And when I put this in my report, the OBGYN called me saying, hey, you have a typo in your report. You said diarrhea. And I'm like, no, that's not a typo. And everybody thought that was absolutely crazy. But I learned this thanks to one of these type of fetal meetings webinars where somebody has shown a case like this and I remembered it. So I went to PubMed, find it out, and boom, it was exactly the same. So save this image in your brain because once you have seen one, you pretty much have seen them all and it can save you. So this baby is now 32 months old. This is a recent picture. She was born at 36 weeks and it was diagnosed with congenital chloride diarrhea. And while the prognosis in these cases is a bit grim, she's stable, she's doing okay. But it's a great case. So although I have an accent, I feel like it wasn't a typo. All right, so last image. After all I showed you, I hope I'm going to look at the chat. I would love if you guys can chime in. So based on the anal dimples I showed you, which one of these two anal dimples do you think is abnormal, A or B? So I'm going to draw up attention to the chat. If you guys can chime in, that'll make it more interactive. Yeah, I see it coming. Great. Love it. All right, exactly. It's B because in this one you have the hypoechoic and the center of hyperechogenicity. And in this one, it looks a bit chubby, as I like to call it, a little bit more rounded, and the line of echogenicity is too small. So look at the anal dimple. We implemented this in our routine ultrasound, routine MRI templates and imaging reports. So keep that in mind. Okay, just to brief summarize. Suspecting rectal malformations when you see bowel dilatation, abnormal meconium in T1, abnormal absent anal dimple. Suspect cloaca if you see dilated vagina, particularly if you see 2 for didelphys. Suspect TEF for indirect signs. We're not that great. And don't forget about the anal dimple. So thank you very much, guys.